Great. I'm just going to say it's just going to do that. Okay. All right. If her colleagues don't know how to say it, then I'm excused. All right. You want to get started? Okay. Good morning, everyone. We're here for the challenging, or coronary challenging case competition, semifinal number 2. So after everyone presents, the panel will pick the top 2 finalists. So we're going to go ahead and get started. I'm Mitul Patel, one of the moderators, here with Megha Prasad, one of the other moderators. You guys just want to introduce yourselves and where you're from, maybe, before we get started? Start with Yash at the end and work our way down.
I'm Yash Chug, and I just finished my fellowship from Minneapolis Heart, and I'm going to be joining faculty at Baylor in Dallas.
Salman Lana from Minneapolis Heart Institute.
Paul Pumiponit from University Hospitals in Cleveland.
All right, so our first competitor is Dr. Megha Fabrionara. Is Megha here? Well, that one was easy to judge. Okay. Well, maybe, I don't know, is Dr. Arain here? Salman, you're here? You want to go first, and then we can just kind of...
Can I use our time too? That way
Yeah, of course, yeah.
Well, thank you everyone for having me here. In full disclosure, I wanted one of my interventional fellows to submit, but they all have new jobs and they couldn't make it, so here we go. In case you're wondering what this old guy doing up here. All right, cool.
Can you guys put up Dr. Arain's slides? Thank you.
How much time do I have, sorry? Typically see those traffic lights, you get the red, the yellow.
5 minutes.
Ooh.
All of 5 minutes.
Oh my God, okay. A lifetime's worth of lessons learned in 5 minutes.
That's right.
So I'm going to take this time unofficially to start, so that way.
Yeah, no, this is not
This
counted
won't count,
for
but
you,
that's my presentation. All right. So, you know, CTOs are challenging. We all know that. A lot of us are doing CTOs. That's why we're here. We're interested. You know, the different techniques, tips, and tricks you can use for the impenetrable cap, all of that becomes much more challenging when the cap is at an angle. So one of the challenges I'm going to show in my case is how to deal with the total occlusion that's at an angle, and especially if it's flush occluded. So that's what makes this case interesting, and some tips and tricks, and perhaps some suggestions on how to overcome those. The presentation, ooh. By the way, this is also how my clinic records look like, always overdue. I'm always perpetually on
Lots
the
of
suspension.
red there.
Perpetually on the suspension list. I did, and I told the guy to check the presentation.
Do you have it on you?
No, it's in my room upstairs. Go to the very bottom. Do you see it? There. Yeah, that one. I'm already in the semifinals. There we go. Okay. So what goes around comes around. Side branch CTO revascularization using a combined approach. This is me. I'm from Texas, not from there originally, but transplanted there. Okay. Next.
Do we have a slide advancer?
Oh, I can do it. Okay. So disclosures, none related to this presentation. This slide should have been there. So 78-year-old man with progressive exertional dyspnea referred to our center with an abnormal stress test. You know, he's obese, he's got back issues, but they did a stress test, found that he had ischemia in the infralateral and lateral walls. He had a diagnostic angiogram at an outside institution that showed total occlusions of the left, of a large OM branch and the RCA. This is what the diagnostic angiogram looks like. We had to plan this case because we needed general anesthesia because he couldn't lie flat. So we had to do as much as we could on this one day. And as you can see that he's got this large OM2 here. that fills late from an epicardial collaterals from the LED. And in case you missed it, there was also collaterals to the to the right. This is our analysis. We decided to target the OM just given that it's more lateral. I think that helps people more with dyspnea, just given the fact that it supplies the papillary muscle, that area. Proximal cap is ambiguous. As you can see, there's a little sort of kink there, but I'm not sure if that's the cap. Lesion length is greater than 20. Mild plaque in the distal vessel is probably underfilled. If you stay on long enough, you can see the target there. And you have some epicardial collaterals, which we tend to avoid. So the plan was antegrade dissection, re-entry, and if that didn't work, we were then going to consider retrograde via the LAD, or perhaps fix the RC, bring him back, and then do the rest. The first thing, imaging, that's one takeaway from all of this conference, is that imaging is key. And here we used IVUS to confirm where we thought the cap was. So what you can see there, that's not a moving image, but you see the arc of calcium on the side. What you see at 7 o'clock, that's not the takeoff. That's actually a branch that comes off an atrial branch. The cap is actually right there at about between 5 and 6 o'clock. So that basically is where the cap is. We confirmed that by using a microcatheter. We were able to engage it with a Gaia to get the microcatheter in. And then we tried to get forward with the Gaia 2. That didn't work. We tried a fighter. I think we tried one other wire. Typically, I use a radar. But as you can see, that's our first strike. So that wire is nowhere close to where the distal target is. And you can see sort of on that still panel, the smaller frame. We then decided to change strategies. And I said, let me try Carlino. We did have the microcatheter in there. I'd injected through that. Again, tried the fighter wire, the fielder wire. We didn't have that. We don't have Mongo, or we didn't have Mongo at this point. So I didn't try any of those wires. We decided to do a lateral cap crush. So you can see there's a wire now in that sort of ongoing circumflex. We did high-pressure angioplasty. And once again, the wire was unable to cross. You can see that that's our second strike. But we felt that we were getting closer, so we said, well, why don't we just engage and take the proximal cap? We know we're subintimal, and perhaps we can use a parallel wire technique. I'm sorry, they're supposed to be on a loop, but they just stop after one. Apologize for that. But here you can see in that sort of still frame, it says strike 3. You see the twin pass catheter is now actually in the vessel, and we thought we had a small branch there, but really it was probably exiting the artery there, and again, that didn't work. So after having spent about an hour just trying to figure out what to do, and imaging really wasn't the best because this was pretty sort of large-sized gentleman, and we could see the radiation counts going up. Even with 7.5 frames, we decided that, and we did notice, now he was anesthetized, so he could not complain of chest pain, but he did have some ST changes, and you can see we had a dissection there. We had IVUS sort of sizing, so we went ahead and stented the mid-circumflex with a stent. And I don't know if I can go back and show that to you again. Is there a way to go back? Okay. And there you can see that we've stented across that area. There's a little bit of a shadow there that might be the subintimal plane, but that looked good. So at that point, typically if it was a patient who perhaps wasn't anesthetized, we thought about bringing him back. The radiation count was already above 3 grays, but we decided to do retrograde. And here you can see in that moving panel, you can see the wire going down, and that's just the apical LED, and that's a SUO wire making its way across the epicardial collateral, and here you can see it hits that distal cap and bounces back into the sort of reflects or ricochets back into the first branch, and in the smaller panel, you can see now the microcatheter turnpike LP following along that SUO. Once we got there, we said, well, this is good. We can now come back. And we tried. And again, we found this very challenging. We started with the Gaia 2, Gaia 3rd, made our way up there, and then we couldn't re-enter. We tried a radar to sort of get around it. That didn't work. We tried a Hornet. And again, the challenge you can see in the still frames that are zoomed in is that that stent is really well deployed. So, imaging means you can deploy stent really well. It's fully expanded, well opposed, so much so that you can't re-enter it. Okay, so what do we do there? So at that point, we had that wire. We decided to use the wire that was in the retrograde channel as our marker wire. And here, sort of this Michelangelo sort of hand of God reaching out to Adam. We have a microcatheter. We've got a second guide, and you can see one guide's retractor, so it's a ping pong technique, if you will. And then we've got another microcatheter there. And this time, again, we had challenges in trying to get across the stent because the stent is so wide there. But what we found is by making this sort of relatively large elbow on an Estado 20, we were able to engage the struts and get through and just basically aim for that wire. Once we got across, we were then able to get our Gaia 3rd down there. Again, I could tell that I was in subintimal plane. At that point, I decided to use a star technique, so basically use the fielder XT and use that for star. So I'm going to go back one and Actually, I made these on a Mac, and I think in transferring them to the PowerPoint, we've lost the sort of loop function. There we go. So you got the star in there. And I know that I'm in the proper channel there. Now, at this point, his radiation count, we were at like 4.9 grays. So we switched to 5 frames, everything fluorescent. So you don't see as many images there, but basically we went ahead and used IVUS to confirm the sizing of the vessel. We were then able to get a wire down. Angioplasty used a long stent, one of, like that's a 38 stent, and then we used culotte. We did kissing balloon inflation. And again, that was a picture of the IVUS, and this is our final there. And we completed just sort of under 5 grays. So that's it. So in summary, compared to main branch occlusion, side branch CTOs are typically more challenging, and the reason is because you're at an angle, you lose all the support that typically you need to get one of these sort of impenetrable caps. Many of these challenges can be overcome using a combined antegrade and retrograde approach. You can modify the antegrade approach to angle it using different techniques. As with any complex intervention, IVUS plays an important role in planning and executing the intervention. The case highlights several techniques. In the combination, we can go between different techniques and algorithms to facilitate cap modification and crossing of the CTO. And finally, it highlights the strategy to treat jailed CTOs. In this case, this was an acute jailing, but sometimes it's more chronic. We can come retrograde and puncture through the stent strut to get to the other side. There you go. Thank you.
Great job, Sal. I think, the other thing that you mentioned there is this is a Texas-sized patient, right? And I think that's one of the bigger challenges. It's great that you have the option of going down to 5 frames. Not all of us have that luxury. I think 7.5 is the lowest our system goes, but great job getting that done.
Yeah, wonderful. Thank you very much.
Is Dr. Febrianora here? Okay. We'll move on to the next talk, A True Challenge, SCAD, COVID and Postpartum, Dr. Brown.
All right, thank you everyone for coming. So like she said, I'm Tori Brown. I'm a second-year resident at the University of Kentucky, and I will be going through a case of a patient, a true challenge, SCAD, COVID, and postpartum. All right, so starting off, just a little background history. We had a 32-year-old female who was 3 months postpartum. Had a past medical history of autoimmune hepatitis. She was actually on a prednisone taper for that. While we saw her, hypothyroidism and PBC, for which she followed with our GI specialist. She presented to our ED overnight with the chief complaint of palpitations and chest pain. So on arrival, she was hemodynamically stable, but she was bradycardic, asymptomatic from that. Labs, mainly, she had elevated LFTs, she was Hep C positive, low TSH, and then had a positive COVID test. She was also asymptomatic from that. The biggest thing was obviously we got troponins and EKG due to the chest pain. Her troponins were elevated and continued to rise while she was in the ED from 190 up to 282 before they started to stabilize. Her EKG had sinus bradycardia and then also demonstrated a competing escape rhythm. So workup for her, our biggest plan was a coronary CTA for her. However, because she was COVID positive at the time, they were unable to get her in for that type of imaging just based on our facilities rules. She went ahead and had a coronary cath, which showed an LAD lesion, 40% narrowing. Of note, it did have a smooth contour, and they mentioned the cath lab that it was a non-typical appearance for SCAD. She went ahead and had a CMR, which showed some late gadolinium enhancement in the distal septum and in the mid-myocardial and sub-endocardial areas. They thought, based on that read, likely embolic infarct based on the enhancements. She also did have an echo, just for completeness. It was unremarkable overall, normal EF, no PFO. So for her etiology, obviously initially we were very concerned for SCAD. You know, she was postpartum. She was, other than her liver issues, she was a previously healthy lady and a young female. However, on the coronary cath, they weren't really sure. It didn't look exactly like SCAD just because of that smooth area of calcium. She had no PFO on echo, so embolic phenomenon was unlikely. And we were kind of still left with SCAD being most likely versus an atypical plaque. She did have no major risk factors for atherosclerosis other than being on steroids, which hadn't even been a chronic steroid taper. So we still felt like giving her history, SCAD was still the most likely cause. So for her treatment, she was started and continued on aspirin and Plavix after discharge, not started on a statin due to her autoimmune hepatitis, and then not started on a beta blocker because she was persistently bradycardic. She was scheduled to follow up with our women's cardiology clinic for a repeat CTA, which is unfortunately still pending at this time. So for her conclusions, you know, there were a couple really challenging areas of this case. One, I think, is the fact, you know, she was actively breastfeeding. Like I said, she was 3 months postpartum. So trying to choose specific medications, you know, that wouldn't be passed through breast milk was a little more difficult. Also, even just her having a CMR with contrast, she had to waste the breast milk for a certain number of days. So that was just an ongoing discussion with her about the risk and benefits. So really just women's cardiovascular health, especially in the postpartum, causes some challenges. She was also COVID positive. I know now that's becoming more and more common, especially just asymptomatic patients. However, at the time it was a challenge because it limited some of the tests that were available and the timing for when she could go for cath. And finally, you know, there was no clear evidence on SCAD on the cath, but just based on her symptoms and how she presented, we still felt like SCAD was the most likely cause. Thank you.
Great presentations. You highlight some really important issues and a lot of work yet to be done in terms of trying to optimize care for the woman, especially postpartum in the cath lab. Turning a little bit to SCAD, how are you guys going through assessing SCAD in the cath lab? Do you, if you're not sure if it's SCAD or not, do you image? Do you not image? Yes, you want to?
So I think, you know, young females with an NSTEMI make me very nervous, first of all. And then if I do have a high suspicion of SCAD, I tend to go groin for access, first of all. I try not to go radial. There's no data, but it's, I think, perhaps less maneuvering of the catheter and less risk of dissection of the left main. In terms of imaging, I think OCT, probably not, just with the hydraulic force of the contrast that we inject. So oftentimes, if it's not a clear, you know, type 1 or type 2A, 2B SCAD, we do turn to IVUS often.
For me, the threshold to do IVUS is pretty high, especially in a patient who has TIMI3 flow, is not hemodynamically or electrically unstable. Because I've been burned in the past as well, in which many times what happens is that you have a patient with normal flow, and now you have, with just wiring and advancing the intravascular catheter, you have now converted, you lose flow, extends, dissection extends, and now you have converted a stable situation into an unstable situation. And most of the times with SCAD, medication treatment is the best option unless the patient is unstable. In those situations, also, and most of the times, in most occasions, you know, SCAD can be diagnosed based on the demographics and the presentation. So my practice has been, I've been very, very conservative when it comes to imaging and diagnosis of SCAD.
I tend to agree. I usually try not to instrument a coronary if I think it's SCAD unless I need to do something with the coronary. If I can't diagnose it on diagnostic angiography, I'm probably going to try and do a cardiac CT and treat them medically.
Yeah, exactly. I think in this case, I found it odd that your CT department wouldn't scan a COVID positive patient, but we could take them to the cath lab where we can expose multiple people to COVID. So
It was very frustrating.
Yeah.
It was a lot of, yeah.
I'm sure these rules are crazy, but I completely agree. If you can avoid instrumentation, that's better. You make the diagnosis, and no need to take them to the lab unless they're unstable in any way electrically, heart failure wise, or having ongoing angina. But great presentation, and congrats on doing this as a second-year resident. It's great.
Thank you.
Yeah, Maggie, you want to take that dual question?
So so 2 things. One is I do DAPT if they've come in with an ACS presentation. I do it for 1 year, especially if there's no other risk factors. And her, we would sort of want to consider in the postpartum state whether aspirin and Plavix, if she wants to continue breastfeeding, is something that's worth that. But the second thing is statins. There's enough data now to support not using statins in these patients. So a lot of times I'll get referrals from other centers where they've been on a statin for a long time. And I think we have enough data now to say DAPT is probably okay, but and has good utility, but a statin's not so much.
Yeah, I mean, there's conflicting data out there. Some people avoid any antiplatelet therapy because it may increase the size of the intramural hematoma and may worsen flow through the lumen, through the true lumen. So, I think the jury's still out on how exactly to manage these patients. I'd love it if someone developed some definitive data or presented some definitive data on this, but I'm not really sure what to do.
I want to add a point. Dr. Gulati from Mayo Clinic has a SCAD registry, and he's actually published papers on this and does recommend use of dual antiplatelet therapy for a year.
I guess I'm fortunate enough to have seen a couple of these patients. I actually have a SCAD expert at my institution, and she's actually been educating me as time goes on. So her recommendation, if you're going to treat them medically, is to only do DAPT for a month. So she actually pulled the patient off Plavix and stopped their statin completely.
All right, thank you very
Thank
much. Our next competitor is, unless Mega Fabrionara has made it to the meeting yet. No, I guess not. So we're going to move on to Dr. Rachel Goodwin for novel use of OCT to find and deploy a dislodged stent within another stent.
Hey guys, I'm Rachel Goodwin. I'm a third-year cardiology fellow at University of Tennessee in Knoxville, and will start my interventional fellowship next year at Mid-America Heart. So we start with a 60-year-old male who presented with refractory angina, found to have an NSTEMI. His troponin I, this was before our high sensitivity troponins, was 13, which is elevated. He had ST depressions in his inferior lateral leads, and his EF was normal, but he did have some hypokinesis of his inferior lateral wall. So with his ongoing pain, we took him urgently to the cath lab, where our angiography showed 100% occlusion of his proximal circ. His LAD and RCA were free of significant disease. Using a 6 French Q35 guide via the radial approach, we attempted multiple balloon angioplasty and were unsuccessful. We had 0 flow. So we used angiojet followed by penumbra until we were finally able to get enough of the thrombus removed so that we could actually see our distal vessel. We decided to proceed with T-stenting of the AV groove circ, followed by the OM1 branch, and determined that OM2 was not salvageable. So we started with the 2012 stent in the AV groove circ, and followed this with a 2520 stent in the OM, which extended into the circ. We then overlapped this with a 3528 stent in the proximal circ in an overlapping manner, and this was our angiographic result. We weren't happy with the way that the AV groove circ looked with the ostium, so we decided we were going to rewire it and try to open that up and place a stent there. We crossed through the stent struts, ballooned open with a 212 NC, and attempted to place a 208 stent there and would not cross, so we pulled it back and realized that the stent was dislodged from the delivery balloon. We looked on high fluoro, we cine, and could not find the stent, assuming that it was within another stent. So this is when we decided, since we had wire access, we would just put an OCT catheter down, and we were able to localize the stent. It was actually in the proximal circ, about 15 millimeters from where the guide was at. And we took a 2015 NC balloon at low pressure just to try to partially inflate that, re-imaged again to make sure that the stent hadn't moved from where we saw it previously. And we did confirm it was in the same place, and we're able to post that and fully expand it with a 325 21 NC balloon. This was our final angio with the OCT, and you can see that the stent was well expanded, and we have 2 layers of stent in the proximal circ. Sorry, I don't have the OCT runs. I attempted to get those to play, but they wouldn't. So to the best of our knowledge, we think this is the first case that has reported actually using OCT to find and then deploy a stent during PCI. This obviously is something we want to avoid in the first place, but OCT is a tool that we can use in a bailout situation along with IVUS. OCT has a lower crossing profile and higher resolution, so you can really visualize the stent. And it also didn't migrate distally with contrast injection, which was interesting as well. So, thanks.
Any questions or comments from the panel? You guys? I think I would, I mean, I'm not going to put you on the spot because you haven't started your interventional fellowship yet, but obviously in these scenarios, to avoid this situation, obviously you found a great way to identify it and ultimately fix the problem, but avoidance is the best strategy. And, you know, if you're going to go through that much stent proximally, you may want to think about a guide extension. Just bury that past all your previously deployed stents, and then you can avoid this, because with that much stent from the prox to mid circumflex, you're going to run into issues similar to this. So, you know, you tried to make a good situation better and paid the price, but found a way to get out of it. So good job. Any questions from the audience? Anyone else? Yeah.
So the only other thing that I would say is, so whenever you're taking a 2.0 stent, you sort of probably want to pause and see, is that really the stent? Like, then this obviously has nothing to do with you, but sort of something to prevent something like this from happening in the future. And when you're in that situation, if you ever are, when you're deploying a 2.0 vessel in a proximal circ, which looked like it was probably a 3.5, it's looked like later, every stent has a sort of chart on the back which can tell you how aggressively and how you're going to get it to the size you're going to get it. So before you deploy it, you want to make sure that you can. Otherwise, a bailout would be put another wire and sort of crush it against the sidewall, because an under-deployed stent is probably worse than crushing it against the sidewall. So that would be my only other comment.
Yeah, having just done that a couple of days ago, I think that's also a very important strategy to know. You can just wire parallel to that, and your OCT can identify where that wire is and just crush the stent into the wall, because a 2.0 stent, I think the Onyx will go up to 3.5, I believe, so I think you were okay there. But in other situations, let's say you lost this in the left main or prox LAD, something like that, where you have a 4.0 vessel, you're better off crushing it. So it's a good point, Mega. All right, great talk. Our next competitor is Dr. Bassam Hennawy, presenting on his worst cath lab nightmare.
Yeah.
All right, welcome.
Thank you. It's my pleasure to present a case in this great event. Yeah, that's the presentation. Our patient is a 57-year-old male. He's a heavy smoker and works as an employee. He had uncontrolled diabetes for 15 years. He was presented by accelerating angina for 2 weeks, and it was worsening on the last 2 days. Physical examination was unremarkable except for harsh vesicular breathing and apical S4. His EKG showed 2 millimeter ST segment depression in anterior leads, and his echocardiography showed mild LV dysfunction, ejection fraction of 45%, and hypokinetic mid-anterior wall and apical segments. His coronary angiography showed this view. He had multiple LAD lesions and total LCX and retrograde filling of the RCA. And that's the LAD. There was ostial LAD lesion, but we appreciated that it's followed by ectasia in the proximal LAD. And then the right coronary was totally occluded, and it filled retrogradely from the left system. So our decision, it's what multivessel disease. The patient was refusing the option of surgery at all from the first. So we decided to begin the revascularization by the totally occluded RCA to see if it will work or not. So we passed a wire. It was a BMW wire. At first, we tried to cross the lesion, and we saw a small dissection at the proximal RCA. And then the nightmare began. This next view, it showed the dissection that extended to the aorta. We stopped for a while to think what should we do, and the patient started to complain of severe chest pain and became tachycardic. So we thought that the dissection began from the proximal RCA, so we tried to seal the dissection by stent. It was the only option we had at this time to seal the dissection inlet from the proximal RCA, and we put a stent. We tried to seal it, but it worked for some extent. It sealed the dissection in the RCA, and still the flap in the ascending aorta is seen. Then we tried to dilate afterwards because the dissection extended distally as well. Still, you can see the flap. And then we tried to follow up the flap. You can see the inlet of the dissection was sealed, but the flap in the ascending aorta is still present. But the patient began to improve, and the chest pain began to be relieved. Then we traced the dissection to see in the descending aorta. Sorry, it didn't extend to the descending aorta, fortunately. And then the patient became more stable and chest pain began to relieve. We were thinking, shall we continue revascularization of the LAD or stop at this point? And the patient was not revascularized at any of the 3 vessels, and he had multi-vessel disease. So we tried to revascularize the LAD, supposedly to be the easiest to revascularize at this time. And the nightmare continued, unfortunately. We put the distal stent in the LAD, it went smooth. This one. We dilated the lesions, and then the proximal stent. There was some calcium in the proximal LAD, so the stent dislodged from the balloon, and it stopped at this point, at the left main LAD, so we inflated it at this point. We inflated it at the left main and proximal LAD, and put another stent in between the two stents in the mid segment of the LAD. And this is the final result of the LAD. We followed the CT aortography for the patient. We did a pot for the proximal stent, and this is the final result. The CT aortography showed the aortic dissection with sparing of all branches, and the patient was doing well. The cardiosurgeons suggested that we should continue on conservative management as long as the side branches are preserved and the patient is going well. We followed him after 4 months, and the condition was stable. The CT aortography follow-up after 4 months was better, and the patient went well all through this period of time. Take-home messages of our case that you should never underestimate the impact of coronary calcification. It was the cause of both complications in this case, and don't negotiate with the coronary calcium. Unfortunately, we didn't have rotablation at this time because it can easily turn your procedure into a horrible nightmare like this one, and try to manage complications in the fastest way, even if it's not the gold standard to treat this. Thank you very much.
All right. Just quick question for you. There's a fascinating case and terrifying in many ways. What would you have done differently now, knowing what happened here? I mean, obviously he survived this. I'm assuming he's doing okay now. Are there any steps you would have avoided or anything you would have done
before the complication happens, right?
Yes.
Yeah. We can treat the calcium more seriously by rotablation or laser or whatever to avoid this dissection and the unmounting of the stent. I didn't find anything else to avoid, especially the aortic dissection. The RCA calcium was not appreciated as well. It was not that severe before we began the case. We didn't expect that it can turn to this. The only thing that we can destroy the calcium first by rotablation, so we can go more easily. In the LAD, we tried to make it as fast as possible to get the patient out of the cath lab to be monitored in the ICU. Maybe the quick intervention of the LAD caused this. We didn't have the time for preparing the lesions better. Preparing the lesions and the calcium is the best way to avoid these complications.
Okay. I have some thoughts, but I want to give the rest of the panel an opportunity. Anyone else have would they have approached this differently, or at least once you identified the aortic dissection, would you have taken a different route here? Anyone? Yeah, thanks.
So general comment is, I thought this case is fascinating. I've never seen anything like this in 20 years. When you have cusp dissections from a guy, typically it's because you've unearthed plaque, typically. Sometimes you go downstream, more often they go downstream, they dissect down the vessel. But sometimes the calcium is so dense that they'll hit the calcium and ricochet back up, and that's what causes the cusp dissection. So you've got a dissection plate. And at that point, stenting the ostium doesn't do the trick, because remember the entry point is distal to where the stent is. And if you ever IR staff in these cases, usually the stent is put in the hematoma. And what made the dissection worse was not so much the stent, I think it's a repeated injection. So one of the things to do is not to inject repeatedly. And if you do have to inject, you disengage the guy, leave the wire down, disengage the guy, and you inject at the ostium rather than into the ostium. And that's why the stent doesn't work, and you're basically, and more often than not, I don't know, the rest of the places, but in the US typically we do conservative therapy. So see cases like this with a lot of complication courses. If the patient is hemodynamically stable, typically just monitor these, and oftentimes these will resolve on their own.
Yeah.
Yeah, thank you, Sal, for those comments. I completely agree. You have to take care of the ostium first, and I've even put in covered stents in this situation at the ostium, because you can get continued leakage of blood into the aorta. So that really is the first step, is you have to fix the ostium and stop injecting. Everything else is IVUS guided at that point. You can't really do OCT because you're going to need to inject. So you just IVUS guide your intervention, disengage your guide, as Sal said, and don't take any more puffs if you don't have to. Typically, the data would suggest if you have an extension of that dissection in the aorta less than 2 centimeters from the ostium and the coronary, they'll do fine. You can get a non-contrast CT because there's already contrast hanging up there if you need something to follow, but typically just manage them very conservatively with beta blockade, et cetera.
Yeah.
But yeah, you really just need to control the ostium. And I would say that at the beginning, your initial wire may have gone subintimal, and that may have created that initial dissection. It's just propagated back. So really, I probably would have stopped injecting. I don't know that I would have done the left coronary system in that same setting. Probably would have brought him back because, that was all chronic disease. I think he felt the right was probably his culprit for his presentation and probably just staged the residual disease in the left coronary system. Any other thoughts?
Ironically, I'm talking about this tomorrow, but you got me beat in terms of the dissection you caused.
That was an incredible flap. I've
Yeah.
seen that flap in the air.
I have palpitations just looking at it. I had a similar case, but I actually stopped because it was a total occlusion. And I didn't have wire control of the vessel. I think if you have wire, so a lot of it depends. If you have wire control of the vessel, typically, as has been stated before, it's within the vessel itself. And so image-guided stenting is going to be your best option, and you should really just stop taking pictures. And in that case, your imaging modality really needs to be IVUS to make sure that you deploy the stent appropriately. It's appropriately sized, so you close the entry point, which is usually within the vessel. In a lot of these cases, if they're small aortic hematomas, you can just treat them medically, and they'll be fine and it'll resolve. I agree with Matul. I probably would not have gone after the LAD. I probably would have stopped, made sure the patient's okay, treat him conservatively, bring him back another day, go after the LAD, probably maybe go after one of the 2 CTOs, but I would have probably used 2 dual guides, and I think that might have been part of the issue as well. If you had dual guides there, you only take one antegrade picture, and then you just start working, and it's about getting to your target.
Thank you.
Yeah, I think that's an important point with all of the cases we're probably going to see today is once you have that first complication, it's not really the first complication that normally gets you in a case. It's the second and third that we hear over and over again as CTO operators. All right, without further ado, great job. Without further ado, we'll move to Dr. Hosseini, who will be talking to us about novel technique for left main trifurcation in interventional PCI.
Okay. Hello, everyone. My name is Maryam. I am a second-year general cardiology fellow at Mayo Clinic in Arizona. Very happy to be here. Actually, which one is it? Oh, okay, got it. Thank you. All right, so I would like to tell you about a very interesting patient case that we had. 67-year-old gentleman who presented with typical angina symptoms, central chest pain radiating to his left arm while he was hiking with his wife. Really unremarkable past medical history, allergies, family history, social history. And he was only on multivitamins at that time. His initial EKG at emergency room showed anterolateral STEMI, as you can see here. Initial exam, he did not have any signs or symptoms of acute decompensated heart failure, and his labs generally unremarkable except for the troponin elevation that you can see. So upon diagnosis of ACS, he was given aspirin and Plavix as usual, and he was taken to cathlab and was found to have a left main trifurcation lesion with severe complete occlusion of the LAD and ostial lesion in the circumflex and ramus as well. His LAD was intervened on. He got a stent in his LAD with good result. It was pre-dilated, post-dilated, and IVUS was used throughout the procedure. At this time, his ramus and circumflex arteries were not intervened on, and he got admitted to the hospital, and we actually got to know about the case the following day as a team. So his echocardiogram showed he had ischemic cardiomyopathy, 35%, with wall motion abnormalities corresponding to his coronary artery disease, as well as an apical LV thrombus. He was started appropriately on anticoagulation and guideline-directed medical therapy. At this time, he was still a little bit symptomatic with very mild shortness of breath, but his chest pain had significantly improved. So given that he did have significant coronary artery disease supplying a large part of his myocardium and ischemic cardiomyopathy and is still a little bit symptomatic, decision was made to go ahead and perform complete revascularization in the same hospitalization. So heart team approach was taken, however, a little bit unusual given that his LAD had already been intervened on at the time of a STEMI day before. So the decision was made to go ahead and perform percutaneous approach as opposed to send him to CABG, even though he was a reasonable case surgical candidate. And the technique that I'm going to explain to you, as far as we know, has never been done before. So we're calling it a double DK crush technique. So it's a modified DK crush technique for bifurcation lesions. So a little bit procedure planning. We use the right femoral artery H range for arterial access, and we also obtained vein access to perform some hemodynamics, which were pretty good. His VIG was only 7, his cardiac index 2.1. We used IVUS throughout the procedure for sizing and lesion assessment. And we also obtained a left femoral artery approach just in case he might need the mechanical support, but we did not use it upfront given his hemodynamics. And as I said, he did have an LV thrombus. And the stent strategy we're gonna go over. So first we IVUS the LAD stent to confirm the location of the stent, and the LAD stent I extended a little bit to the left main. And for the interest of the time, I'm not gonna play the whole IVUS. And these are the sizings of the left main, LAD, left circumflex artery, and the ramus. So the first stent, and on all my steps I have graphic on the other side of the screen so you can see, but the first step was to crush the stent in the LAD that had already been placed there. So we take a balloon and crush it initially. Then we did PCI on the other side branch, circumflex artery. So in this technique, the ramus is treated as the main branch, and the LAD and circumflex arteries are side branches. So LAD stent already there crushed, and now we are stenting the other side branch. And as you can imagine, we're going to crush that one too. So now both of the side branches are stented and crushed. Next, we perform KBI of the main vessel and one of the side branches, and we're going to repeat it on the top two. So KBI times 2 on the side branch and main branch on both sides. Okay. Then we perform PCI on the main branch, the intermediate artery. So in this stent is a Megatron stent, and it extends all the way to the left main to cover the whole lesion. And we perform POT, and we're going to repeat it again. That's why we're calling it double DK crush. So KBI on the both sides, top and bottom, with a final POT technique, as usual. So this is the final result. The whole procedure took about an hour. IVUS was used throughout, before and after. Patient tolerated the procedure really well with no complications. On the right side, we did use a preclosure device because it was an 8-French, and he was transferred back to the floor in a stable hemodynamic condition with no complications. So this is the whole steps in one picture again. We started with the stent, and the LAD was already there, so all we needed to do was crush it, stent the other side branch, crush it again, KBI, stent the main vessel, KBI again, and POT at the end. So 3 stents overall. About 3 months later, an echocardiogram showed that he had improvement on his ischemic cardiomyopathy. He was tolerating his medications really well, and his LV thrombus had resolved. His symptoms also were significantly improved, and he was back to his physical activity with no limitations. So in a little bit discussion, left main trifurcation lesions can be very complicated and challenging, and most patients end up with CABG due to high syntax score. And to date, as far as we know, there's no really therapy or management technique that's recommended that has a strong evidence for it for left main trifurcation lesion. And again, this case was a little bit unusual because once we got to know the patient, he had already had an LAD stent with good result. So we think that this technique could be considered for situations like this, and is, at least in our case, was good outcome. The limitations, of course, is that the LAD is a side branch, and it can, as all side branches that we see indicate bifurcation lesions, it does have an increased risk of in-stent restenosis. But, and the other thing is it's complex and it's challenging, requires expertise, but that's also the same for any other technique that we learn. And that's it. Any questions?
No, it was a great example of what to do. I think, I guess one question I would have is if this patient presented, let's say, with that same anatomy, but the LAD was, say, 90% osteal lesion, how obviously the surgical route would have been an option, but if they weren't a surgical candidate, how would you have approached it in that circumstance? Would you have chosen your circ and ramus to be side branches, or how would you have approached it?
Probably knowing my attending, Dr. Rebecca Chester, she had this idea already. So I asked her that question, if the patient didn't have the LAD stent, what would have you done? And let's say the patient is not a surgical candidate. And she actually said she would have tried to do percutaneous approach like this.
So using the circ and the ramus as side branches, and then left main to LAD as your parent. Yeah, I think that's probably the right way to do this. You know, it's you can talk about all types of bifurcation strategies, but I think ultimately the anatomy and the angles determine what the best approach is. And in this situation, you had to get a bit creative because of the original LAD occlusion that you had to manage. Anyone from the audience have any questions, or anyone on the panel have any comments or questions?
So I guess one other thing to think about is, you go balloon the LAD, restore flow, and if the patient is stable, call your surgeons and see if they would then consider bypass. And I guess if not, our goal would probably be to reduce as much stent you would use, as much hardware as you would use in the coronary. So perhaps you do a DK of the circ and LAD and perhaps balloon the ramus and see how she does or he does and bring them back.
The one thought that I just want to say out, although the Flower AMI trial argued against it, the use of invasive assessment of these lesions before taking on, especially trifurcation stenting, in which the risk of in-stent restenosis would be higher. Not in the same setting because it was close to the target at the area of the acute MI, but I mean, in this situation, I think food for thought that, that if the ramus, for example, is not significant, would you have approaches differently? Or maybe both of those lesions were not significant and had to be left alone. So again, the Flower AMI trial argues against it because there was no difference when compared to the angiography versus FFR guided. But in these kind of situations, I think that it may be worthwhile doing it. Of course, no backup with data, but.
Yep. Would anyone do planned surveillance imaging on this patient, knowing how you had to treat it? Anyone? Yeah. Yeah, agreed. Yeah. Great case, thank you.
Thank you so much.
All right, so our next competitor is Dr. Umar Ismail talking about coronary artery dissection. Oh, no, sorry, I skipped one. Left main intervention always makes sure the results. So this is Dr. Ahmed Kamal.
Good morning. I'm Dr. Ahmed Kamal, Lecturer of Cardiology, Arain Hospital, Cairo University. I'm glad to present my case, left main intervention, always make sure of the result. 48-year-old gentleman. He has been treated as chronic stable angina for the past 3 years and kept on optical medical treatment. Recently, he presented to us with unstable angina. His ECG, echocardiography, and cardiac enzymes were unremarkable, so we decided to go for diagnostic coronary angiography. Here, as we can see, there is a PDA moderate lesion on RC in the right coronary angiography. Ramus branch shows significant lesion starting from the ostium. The LAD was normal. Now we have a Medina classification, 001. We have a long normal left main, small non-dominant LCX. Plaque in the Ramus branch is reaching the ostium. We had our discussion with our team. There was proximal landing zone of the stent, whether we have to stent only the ostium of the Ramus branch or we have to extend to the left main. And also we discussed whether it is provisional versus two-stent strategy. Our plan was to do a provisional stenting strategy, and the proximal landing zone of the stent will be in the middle of the left main. We had 2 wires, BMW and Asahi soft wire in the Ramus branch and LAD. A 4x28 millimeter drug-eluting stent was deployed in the mid-left main to Ramus branch, covering the lesion. The problem with the presentation.
While they're bringing that back up, maybe we can discuss a little bit about ostial branch lesions here. I think, many people try to land these stents perfectly right at the ostia, but when you have a true ostial lesion, oh, here you go, I think it's important just to go ahead and stent across into the left main.
Yes,
so I think most people would probably agree with this strategy.
It will be very difficult to just stop at the ostium.
Right.
After we deployed the stent, there was incomplete expansion of the stent in the proximal segment, and there was some pinching of the ostium of the LAD, as shown here. We had wire recrossing and stent optimization using 4x80 millimeter NC balloon. We do final kissing using 2.75 times 15 millimeter balloon in the LAD and 3.5 times 24 millimeter balloon in the Ramus branch. And we had a good final result. STEMI3 flow in the LAD and the Ramus branch, which appears to be a very huge branch. The patient was discharged. 2 days later, the patient complained from mild chest pain that was persistent and different in character, but milder than before PCI. Cardiac enzymes were slightly elevated with no changes in the ECG. We had 2 opinions in our heart team. First opinion was conservative treatment with reassurance of the patient and keep following the ECG and cardiac enzymes. Second opinion was to go for second look coronary angiography, especially this was left main intervention. Our second look angiography. As you can see here, everything seems fine. However, when we took another views, as we can see here, there is a dissection and intramural hematoma in the LAD that was not appreciated in the first PCI. We had 2 wires in the LAD and Ramus branch. It stopped working. Please, the video is not working.
Are you able to play that by just clicking on the
Okay.
Okay. We adopted a tap technique to put stent in the LAD. We do kissing balloons. We had a final result, which was good for the LAD and the ramus branch. And as we can see here on the right panel, on the left panel, the intramural hematoma was seen. This is before the PCI, and after the PCI on the right panel, the hematoma resolved. And on the spot, the chest pain that the patient had resolved immediately after putting the stent. Take-home messages: always make sure of the angiographic results in more than one orthogonal view. Don't neglect patient complaint, especially after complex procedures. And the last one is the most important one, is that intracoronary imaging tool, e.g. IVUS or OCT, are very valuable and should be used when needed, which we miss in our case, that could detect the complication easier and help our management. Thank you.
Any questions from the audience or the panel? Any input? Paul?
I guess a question for the first index procedure, did you guys image that or no?
No.
No? So I guess for the fellows out there, I image all my left mains, I image all my prox LADs, I image all my CTOs. Anytime I'm using more than one stent, I image, because we have data out there that demonstrates that in those cases, and probably every single stent we place, we probably should be imaging, because otherwise we're going to undersize our stents and we're going to have malapposition. So I guess the only thing I would have done differently is I probably would have imaged up front, give my vessel sizes, and then go through the math and figure out what to do.
That's very true.
Yeah, agreed. And I think, you know, it's always a little bit nerve-wracking when you're stenting from the left main to a ramus, right? Because your LAD here is probably the most important of the branches. Now, that is a big ramus, and it was a small, very small non-dominant circumflex. So I can see stenting across the circumflex. But anytime you're going to stent across the LAD, as Paul mentioned, I'd probably image that LAD too, because you may have noticed there may have been some plaque there that was disrupted with your kissing balloon inflation.
Yes, the kissing balloon and then the dissection.
Right, and then so if you would have seen that plaque on imaging in the LAD, you probably would have chosen a different strategy. You may have stented LAD to left main and done a DK crush or a culotte or something like that to manage that bifurcation. So. That's
true. Unfortunately, we don't have an IVUS on shelf in our lab, so we had to order pre.
I see.
So we adopted the strategy. We think that the left main is normal, and we can just stop in the mid and the left main, and nothing will happen to the LAD. But unfortunately, that's what happened.
Yep. Lessons learned.
Yes.
Good. Nice case. Thank you. Yeah. Yeah.
So I actually normally image first, and the reason for that is I image first and then I image again after. And the reason for that is if I leave a dissection behind, I want to make sure that if I'm going to do a gentle inflation, that there's no dissection that I'm not appreciating angiographically, because then, you know, the patient develops chest pain when you've gone home, and now you've got to come back and rescue a vessel. So that's the reason I tend to image first, and then even from the imaging, I undersize if I don't want to stent it. But of course, whenever you're doing that, you have to be ready to stent if you need to.
Yeah, same. I usually let image guide what I'm going to do, but if I can't get an imaging catheter down there for whatever reason, I usually at least try to get a 2.5 balloon to open up the strut, but it's very dependent on angles and anatomy.
I just want to make a comment about, you know, physiology again that we talked about in the last case. I think sometimes after provisional stenting, these side branches tend to look bad, probably worse, and oftentimes you'll be surprised that the IFR or FFR is normal, and you can probably walk away.
Exactly.
I think one question I do have is how often, as we as interventional cardiology community, doing kissing balloons after a provisional stenting? And that varies a lot from operator to operator. Some people are very conservative, some people aggressive, and so and I don't have an answer to that. It's just that that if you're talking about undersizing balloons and distorting the stents, and we rather many times may have to just accept the provisional, especially if there's no stenosis of the side branch. And again, the question also becomes, if you've stented across the LAD, whether you want to, in that situation, because LAD is your most important vessel, whether you want to do bifurcation, just kissing balloon angioplasty after that. And I would be interested to know what the audience of the panel thinks about that.
Yeah, I mean, I think it all depends on where you're working. I feel like, if it's an LAD diag bifurcation, I may not even recross or do anything. There's TIMI 3 flow, patient's doing fine. But when you're talking about, let's say, the left main with a dominant circumflex, then, I'm going to end that with a kissing balloon because I just want to make sure those struts are open. Whether that's right or wrong, I don't know. But nowadays we're doing a lot more finishing with a final pot as well to make sure that architecture is favorable. But yeah, for me it just depends on where I'm working and whether it's a large side branch or not, on whether I finish with a kiss.
And that's a great point. So I think when we do this, really you're actually right. We're going to go to trouble of the side branch balloon that might as well stand. But it's just in the future if you anticipate coming back. So if you have maybe disease downstream from the circle and progress, especially in the relatively young patient. Not so much an issue now because we have this thin strut stents, but when I was in fellowship, we had stainless steel, first generation cipher taxes. We know that it was extremely hard to cross these after a while. Partly because if we ever go to those, you can see how the neointimal form, the neointimal creeps along the strut. So the strut goes across the diag. The neointimal creeps along and makes that a little bit more stiffer. So angioplasty, opening up the struts, a little easier in fresh decoy stent, especially in hot, rather than if you come back 5 years later trying to get this neointimal and trying to get back to stretch. Sometimes the fiber elasticity of the neointimal keeps it from happening optimally. So
Yeah.
I tend to agree with what Matul said. If it's a LAD diag, I mean, the LAD is your lifeline. The diag's a diag. And a lot of it depends on if there's disease in the ostium or your side branch or not, right? If I'm stenting left main into the LAD more times than not, I'm at least trying to open some struts into the circumflex artery, especially if there's disease you anticipate in the future. But as others have said, I'm probably going to use an undersized balloon just to be able to get access to that vessel in the future. But if it's a different bifurcation like LAD diag, I'm probably not going after the diag and not trying to kiss unless there's disease there.
Yeah, that's a great point, Sal, about the struts. We're spoiled these days. I've delivered some cipher and taxis stents back in the day, and you're absolutely right. Okay, let's move on to our next competitor. This is Dr. Judit is how I'm going to leave it, because I asked your colleagues how to say your last name, and neither of them know either. So she's going to be talking to us about ostial right coronary chronic total occlusion and when to stop.
Okay. Thank you. So my name is Judit Karacsonyi. I'm a research fellow working with Dr. Brolakis at the Minneapolis Heart Institute, and it's a pleasure to present our case. It's an ostial RCA-CTO occlusion, and the question is, when do you stop? I do not have any disclosures. So our patient is a 66-year-old gentleman who presented with a medically refractory stable angina. He has multiple comorbidities. He had an STEMI 9 years ago, which was treated with a cabbage surgery. And 7 months ago, he underwent coronary angiography, which found the RCA-CTO and a patent graft. He also underwent stress testing with MRI, which showed ischemia in the RCA territory and viability. And on echo, he had moderately decreased ejection fraction and wall motion abnormalities on the inferior wall. So these are the angiographic images. We can see that there is a significant lesion at the distal part of the left main. The SVG to the LAD graft is patent. We have a patent SVG-OM graft with collaterals to the RCA and also an intact lemma to the diagonal branch. And this is our target lesion, the RCA. It's an ostial occlusion. It's a very calcified, tortuous vessel, and the lesion length is approximately 100 millimeters. There is a bifurcation at the distal cap, and we have collaterals, septals from the LAD, and epicardials from the SVG-OM. So based on these angiographic characteristics, our plan was to start with a primary retrograde approach through the septals from the LAD, and then continue with the retrograde approach from the epicardials through the OM, and then later on proceed with antegrade crossing strategies if the previous ones are not successful. So the plan was first to start with the septals from the LAD. What we could cross this significant lesion in the distal part of the left main with the Sion, but nothing would cross after that, so it was a balloon crossable lesion. Even the small 1.5 balloons wouldn't proceed here, so we had to give up this approach. And then we switched to the SVG-OM, and we tried to cross these epicardial collaterals. There is a clear connection between the SVG-OM to the distal part of the RCA, but the collaterals were tortuous, and there was a significant angle in the proximal part of the collateral. So we did micro-injections to have better visualization of these collaterals. And then we used the SUO3 guide wire. It had difficulty to overcome the angled, tortuous epicardial collaterals, but after a couple of minutes, we could successfully cross to the distal RCA with the SUO3, and we were at the distal cap of the bifurcation. But then the Corsair XS could not pass further. We tried to knuckle the Mongo guide wire to cross the distal cap, but unfortunately the Mongo guide wire entangled in the microcatheter, so we had to remove the whole system, microcatheter, guide wire, and start again. So we used then a turnpike LP to cross again the collaterals which we crossed before, and we could regain our position at the distal cap and tried multiple guide wires. Nothing would cross except the Mongo guide wire could go to the distal part of the RCA in the subintimal space, but there was not enough support. So then we decided to switch the microcatheter, and with more support with the Corsair Pro microcatheter, we could cross the Mongo all the way to the proximal part of the RCA. And now we have a marker from the distal part, and we could switch to the antegrade approach with a Corsair Pro and several guide wires to cross the proximal cap. Finally, an Astat 020 would successfully cross to the subintimal space, and then we did predilations in the proximal RCA and delivered a 7 French guideliner. And then we performed the guideliner-assisted reverse cart and crossed with the Mongo guide wire to the antegrade guide. So then after this, we externalized with an R350, and we did predilations along the whole vessels with 2.0 and 2.5 millimeter balloons. So we have now the main branch of the RCA open, but there is still a big PL branch, which we tried to recanalize. We tried with several guide wires again, but all of them went extra plaque. And also the guide wires kept entering into the inferior branch of the PL, not to the main branch of the PL. So we tried to assess if we could cross this lesion from retrograde again through the epicardials, but these epicardials were very small and very tortuous, so we decided that the risk is not worth it for this side branch. We tried to deliver a Stingray to cross from antegrade with the ADR, but it couldn't be delivered, so it was not successful at this point. We decided to treat the main vessel, so we decided to put 2.5 by 30 millimeter DES in the PDA after predilations, and then delivered 3.0 by 38 to the distal RCA, another one to the proximal part of the vessel. And then we also covered the ostium with a 3.5 by 28 millimeter DES. All the stents were then imaged with IVUS and optimized. And then this was the final result from one projection. And the final result from another projection, we can see that the flow is good in the main branch, and the stents are well expanded, but the PL has significant dissections. There is some flow there, but at this point, after 348 minutes, 131 minutes of fluoroscopy and 5.2 grays, 280 milliliters of contrast, we decided to leave the procedure at this point, and if the patient still has angina after this, then bring back him later on for the PL. So to conclude, beware of prior CABG patients because there is significant calcification, tortuosity in these cases, and it could get very complex. Ostial lesions could be overcome by primary retrograde approach, as we could see in our case. Epicardial collateral crossing is very difficult because of the tortuosity of the vessel and usually the small size, but in our case, the SUL 3-guide wire could cross the epicardials. Equipment delivery through heavy calcification can be challenging. As we could see, we had the Mongo wire angled in the microcatheter, and that's why we had to remove the whole system and start again from scratch. But we have to be aware of these heavy calcifications. And the perfect result is not always feasible. We always have to assess the risks and the benefits of the procedure and assess the patient in these cases. Thank you for your attention. And I'm happy to take any questions.
Wow, Judit, that was fantastic. I think I commend you and Dr. Berlakis' fortitude to get through that and to persist and try to get that PLV even after everything you had done is certainly commendable. One quick question I had, did you have that PL wire trapped underneath all of those 38 millimeter stents? And was there, if so, was there any trouble removing that at the end?
Yeah, there was no trouble removing it. It was trapped at some point, but there was no trouble removing it.
Yeah, I've gotten myself into trouble with that at times, but I'm glad you were able to get that out. Anyone else have any questions, comments?
Yeah, I've done that before and actually had to break the wire and do other fancy things in order to get stuff taken care of. That was an amazing case. You're encroaching on my record for a case. I guess the only thing I probably would have done differently is I probably would have just knuckled the wire in the PLB and tried to balloon it and then just stent the rest of it and call it a day, to be honest with you. But I mean, that's a great case.
At least not the one time, remember when we did the 6-hour case, and when we stopped, I guess at 3 hours, but I told Seyedeh that the Manos is a great teacher, and sometimes he has resilience and he has stamina.
Yeah, and I can share a similar story. He was my original CTO proctor for our lab too, and it was a retrograde right that took us forever, and he's just very patient. I think this speaks to kind of proctorship and how we can spread the skill set and the knowledge to address these very, very difficult cases. And yeah, Manos is, I don't know if he's in the room or not, but thank you for doing this, getting this started, and for helping many of us kick off our careers with these crazy, complex CTOs and whatnot. So thank you very much. That was great. Okay, I guess we have some voting to do up here at the panel, but I'm not sure. Do the AV folks, do you guys know if we're supposed to announce the winners here, or is that something that we announce later? All right, we'll just announce it here. Give us a minute.
All right, so we've got two winners. We've got Dr. Judit, because I'm not going to mess up your name. Congratulations. And Dr. Hosseini. Congratulations.
So stick around. You guys will, I think, go on to the next round, which is Friday or Saturday. I'm not sure. So hopefully your flight plans can accommodate these. So thank you all for your attention, and we'll see you at the next session.
Okay, good. I was making sure I'm not here on Saturday because my flight plans can't.
I'm leaving tonight.
It's like between Seattle and here.
Oh, you came straight from there. Did you do the 3 days with or 2 days with Bill afterwards?